Hello, good afternoon, students. I hope you guys are ready to learn new skills in shared decision making so that you could handle those people that are resistant to your advice for chronic diseases. So here are the learning objectives for this e-learning session. After this particular session, you should be able to describe a framework for shared decision making. You should also be able to elaborate on the relationship of SDM and patients' beliefs and preferences. And lastly, be able to describe the correlation of SDM and the ICE framework, which is the ideas, concerns, and expectations framework that you've already learned, and how SDM leads to person-centered care. And the goal of our session today is to demonstrate how shared decisions may be reached in a setting of using antihypertensives and the management of high blood pressure. Now, let's start first talking about patient preferences, values, and beliefs. What are patient preferences? Well, they can be religious or spiritual, social or cultural values, thoughts about what constitutes quality of life, personal priorities, and beliefs about health. Now, everyone is subject to their own values and belief systems, right? In order for us to create a rapport with the patients that we work with or even their caregivers, it's important for us to understand where they're coming from, just so that we can reach out to them and talk to them at a level at which they can identify with. So, what really is SDM? It really is an approach where health professionals and patients make decisions together using the best available evidence about the likely benefits and harms of each option. So it requires for us as healthcare professionals to know and be very well versed with the pros and cons, with the evidence involved in using each option, right? And where patients are supported to arrive at informed preferences. It is therefore not letting patients have whatever they want, wasting time when it's already clear what is best for patient, and abandoning them to make decisions on their own or just being nice to patient. So when and where is SDM appropriate? Now, SDM is appropriate in almost every situation in the community, in the primary and secondary care setting, where a care decision has to be made, and the decision is said to be preference sensitive. For example, where there's more than one reasonable course of action and the decision involves a trade-off, for example, the length of life or the quality of life. One probably would think about perhaps cancer treatments, whereby there are several courses of cancer treatments, maybe in the second line and third line, and there may be certain side effect profiles of certain medications, but they could be more effective in prolonging your length of life, but may be ridden with more side effect profiles. So this is a setting where there are more than one reasonable course of action. Now, the second scenario is where there's uncertainty or unclear evidence for one option over another. You see, we all think that everything that we offer our patients is really evidence-based. But actually, at least half the time, we don't really have evidence-based medicine, right? Because randomized controlled trials would usually select or cherry pick patients according to the inclusion-exclusion criteria. And a lot of times, many of the patients that we see on a day-to-day basis does not meet those inclusion-exclusion criteria. And therefore, most of the time, a lot of evidence that we know today may not always be applicable to the patients. So when there's uncertainty or unclear evidence, that's when we involve the patients and their caregivers in order to make decisions together, giving them all the full preferences and choices laid out and what are the risks and benefits of each approach, including the costs as well, especially when medications or treatments can cost different amounts. Lastly, when the options have different inherent risks or benefits, or where the individual values are important in optimizing that decision. Now, look no further than, say, the setting of use of, say, an ACE inhibitor versus Entresto, which is really expensive for heart failure treatments. Now, Entresto can cost you up to $8 to $9 a day, right? Now, if essentially I tell you that the likelihood of benefit, right, would only be 3 more persons as opposed to someone who used ACE, which is cheap and good, would you then choose the more expensive agent if you really cannot afford it? Now, if you can afford it, you might actually say, okay, let's go for the Mercedes Benz, right? Or if you cannot afford it, you might just say, maybe a Daihatsu is good enough. So we're not saying that we are depriving patients in any way. We're just saying that we essentially give them all these inherent risks or benefits and what really you value to be important to you. So the one thing we must understand is shared decision making results in person-centered care. Why is that so? And why do we say person-centered care and not patient-centered care? Now, we want people to think about our patients as persons, not as a patient. Because when we think of someone as a patient, you tend to, well, lord over them and give them instructions rather than have them as one of a person at the same level of decision making as you. So really what SEM results in is really having all the multidisciplinary people around the patient and giving them all the possible options as a team together. Now, each of the team members must be able to say the same things and must be aligned in expectations as well as the plan to treat the patients. Otherwise, these people will be very confused, as would be the caregivers. So this all the more would then assemble the whole multidisciplinary team around the patient rather than having us all doing our solo care for our patient one-on-one with our individual disciplines. So you will see many framework and literature, and this is an American approach of how shared decision making is done, and it's called the share approach. It's got 5 steps. Now you might also see the UK approach, which is the 3 talk approach. Now, essentially, there are many frameworks, and you can be free to use whichever framework you prefer. However, today I'll be sharing with you something that's developed locally. Before I embark on the local framework, I'd like to introduce some common frameworks that are used or techniques used by different people. There could be ORS, which stand for open-ended questions. A stands for affirmations, which you would probably bring up past successes of the patients or the caregivers and affirm them or encourage them. You can also use reflection, where you can have a simple repeat and paraphrase what patients seem to be reflecting to you, right? They are saying something to you, you're saying, oh, this is what I hear from what you're saying. Do you mean, right? Or it can even be complex, where you can infer what the client has unspoken or implicit meaning to you. So they might be saying a lot of things, but actually you're reading between the lines and you're summarizing to them what you think they're trying to say. Lastly, S stands for summaries, where you summarize up what you've heard from them. So in this whole approach where O and A are concerned, sometimes even where just before you reach the R, you could be using the EPE or elicit, provide, and elicit framework or technique of interviewing your patients or talking with them. Now, the first E stands for elicit, which you would probably spend some time understanding what existing knowledge that this person might have. Do not ever assume that your patient or your caregivers know everything, or even though when sometimes they try and tell you what they know, right? Don't always assume that they understand everything. But at the same time, when you talk with them, right, you have to respect them, and don't talk to them as though they know nothing, right? They can get insulted that way as well. So it's also important to elicit the interests, priorities, and whatever ideas they have. Now, remember that patients will always have their own ideas, right? But we try to impose our ideas on them, right? And that's when they get really defensive and offended with us. Lastly, always ask for permission before you either move on to another topic or give them more information, because they may not actually be ready if you do not ask them for permission to move on to another segment of conversation. So where P is concerned, we'll provide things like affirmation, we'll provide information. Now this information needs to be brief and tailored. And you might also give them a menu to select from whatever they might be interested to listen to more of. Also give them autonomy and support where choice is concerned. Now don't try to force things down people's throats, because people have their own ideas about what their priorities are and they don't like to be told what to do. Remember the last time your mom tried to tell you to do something when you're not happy? Well, this is the same with any person, right? Let it alone be a patient who is in doubt, right? They will always have their own ideas and preferences. And lastly, elicit again after you've provided information. What are the reactions, right? What are the additional questions that they might have? And what are the next steps to take together? So I'd like to highlight John Engel's framework, the need for biopsychosocial aspects, thinking about the other aspects beyond the biological aspects. Now, as healthcare professionals, right, we're very well trained about disease management. Or when we talk about hypertension, for example, right, we think about how blood pressure is high because you take a lot of salt, you don't exercise, you're overweight. Now, we are very, very skilled in that, and we feel like we need to tell our patients the 101 things that we've been trained to tell them. Now, that's not the right approach to things, mainly because you think about how there's an informational overload for a layperson, right? They probably have heard a lot of this, or maybe they've not heard about this before. Now, think about the last time when someone points out to you,
hey, you got a lot of things that you need to change about yourself. Now, how do you feel about it when they tell you, oh, I've got 1, 2, 3, 4 laundry list of things that you need to change? Now, as a person, a lay person, even with your friends or your relatives trying to tell you all that, it's already not a nice feeling, let alone an adult who has been maybe practicing their way for the last 40 years or 50 years of their lives at the time that they present to you. So it's critically important to explore the psychological aspects of what the value systems are, what they're thinking, as well as the social aspects, the influences of friends, the influences of their family, and what family even has got values, that impose upon them. So essentially, it's very important, right, to think about how the biomedical aspects of things, right, can be woven into how the person thinks and how the social setup is for your patient. So how do we use the BPS framework? It's very important when we are attending the patient, right, to use layperson language. Now, if you use a lot of medical jargon, right, it's going to make a patient think you're trying to high horse me or something, right? We also, it's important to identify persons presenting issues because they may have their own agenda or they may have their own thinking about why they've come to see you in the clinic today. They may actually even have been thinking that they're seeing a doctor in clinic. Now, if imagine they're shocked if they come in, you're a pharmacist, then all the things that they want to talk to the doctor about, right, they cannot talk to the doctor about anymore. So as we've talked to you about ICE framework, right, your ideas, the concerns, the expectations, it's always important to solicit what the person has an ICE about first, right? Then first you use your open-ended questions to elicit presenting issues, and then target one area which a person wants to talk about, not your agenda, but the lay person's agenda. Maybe because they came to clinic and they have high blood pressure, but actually they have got this pain that they wanted to talk to somebody about. So it's very important for you to talk to this person, to talk about maybe deal with the expectations. Now, don't brush the person's concern aside just because you're the healthcare professional who's attending to their blood pressure today. Always tell them, assess the red flags, right? Whether it's urgent enough or important enough to highlight to a doctor, and then manage them by saying, oh, I understand that you have a toe pain. Actually, today I have you're supposed to come to clinic because we need to talk to you about quitting smoking or managing your blood pressure. Do you think that this is something that I can work with you later to refer you to a doctor who can attend to your toe pain, for example? So how do we ask BPS related questions? So these are examples. What is a biologically related question that you can think about soliciting from your patient, right? Maybe you are working with them about blood pressure readings and their blood pressure is poorly controlled. You can ask them, how often are your blood pressure readings high? So an example of psychological aspects of things is how does high blood pressure readings make you feel? What are the reasons that you have not been coming for your regular follow-up, uncle? Is it because you have struggles with your work shifts that we can help you with, right? A social aspect would be maybe the work life, family life aspects of how it affects the resolve to quit smoking. Now, I remember all too often when we work with high-tech patients, they need to stop smoking, right? And as long as you don't know that smoking is harmful for their health, but you know how it is with friends and relatives when they hang around. And because it's an addiction, smoking is an addiction. So when they see their friends and family, they have that feeling of that high when they smoke. You can imagine that it's very easy for them to relapse, right? So instead of nagging your patient to death in the clinic setting or in the pharmacy setting where you're talking with a person, right, it might be more effective to call up their friends whom they hang around a lot with or their family. So it's critically important to find out from your patients whom has got the most influence on them, where they spend the most time. I remember I had patients who at the workplace, right, at break times or at lunchtime, the first thing they do is to hide in the stairwell so that they can all smoke together. So it might be important to call their best friends or their colleagues up and talk with them about the need for them to encourage this patient or this person that you're working with instead by not smoking when this person is around them. So it's really important to use this framework to identify ambivalence, conflicts and beliefs, values and context and environment. And those are examples that I've just given you above. Remember to always use ORs, and we've covered this already. Use open-ended questions, use affirmations. Perhaps the person had quit smoking before and did well, but relapsed because of family members or friends. Then that's the time where you say, oh, well done. You see, you've done it before. You can do it again. So let's work together. What do you think you will allow me to do? Can I call your family? Can I call your friends to work with them? And whenever they give you sort of reflections, right, try to paraphrase them by making them feel heard. Right? So these are very important concepts that as healthcare professionals, we need to pay attention to.
Okay, let's get to the summarize and teach back part of things. Now, the last S in OR stands for summarize. So what do I mean by summarize? Now, after the whole interview process is over and you've elicited all the information you want, it's important to establish the area of focus where the patient or the person wants to receive more information or set a goal collaboratively with you, right? So think about the last time when your mom nagged you about like 10,000 things, and essentially you want to also focus on something that you will co-agree with her, because otherwise if she nags you about everything under the sun, you're not going to be able to also work on everything, and therefore it makes it very difficult for you to accept, right? So it's the same thing where maybe you have a patient who has overweight problems. He also eats unhealthily, and therefore his cholesterol and diabetes are poorly controlled. He also has blood pressure issues where, you know, he's non-compliant with medications, and you would like him to monitor his blood pressure, but he has difficulty because of shifts. It could also be that the person is also still smoking, right? Now, you're more likely to get a success on the patients achieving a goal when you collaboratively try to prioritize issues, right? You let them choose what they think they want to work on first. But of course, you have to list out that, oh, you've got 5 issues today. So why don't you work with me to choose the thing that you think can work on first? So elicit what the person already knows about this particular area. Don't assume that they know nothing, but also don't assume that they know everything. It's important to fill in the blanks according to the context that we're talking about. You should also ask permission to share more. Don't try to like rattle off from A to Z about everything that you know, because it can cause the patient to be really impatient, right? When they think that they're here to get a particular thing and your agenda is a particular thing, you end up nagging them for longer than they expect. Give information that is brief and tailored to their condition. Don't try to tell them about XYZ, everything that is not related to them. You might also want to give them a menu to choose from, which gives the sense of autonomy, right? So if going back to the area of focus that the person wants to work on, right, you tell them, oh, okay, so you've got these 5 problems, right? So you want to work on, say, blood pressure first. Then, okay, you've got perhaps the possibility of taking medications on time. You want to explore methods of doing that, or do you want to explore methods on monitoring your blood pressure more regularly, right? And always use lay language in manageable chunks. Don't try to give them too much complex terms. Otherwise, people cannot handle, right? It's an information overload. Give information about disease conditions. It can also be options about what medications are possible and what the side effect profiles, what the prices involved. And so this is a very good example where we're going to go forth in our practice session on the multiple choices of antihypertensives available. So also important to elicit how the person understands the information, right? Don't just try and like download all the information and then you don't stop to even see where their understanding is at before you try to force in more information to that person. Okay, so always choose and watch the expression of the person that you're talking to, and don't try to just because you prepared all your script, right, to try and download everything on them. You might have to prioritize and try to maybe choose your battles to fight each time. So also ask for permission to transit or signpost to another item, like perhaps you want to talk about other things now, or maybe you want to shift to teaching them how to fill a chart where the blood pressure readings are concerned, right? So let them know that you're transiting and signpost your conversation. Okay, so again, you will see the whole framework of elicit, provide, and elicit happening here again. And so this is a very useful framework that you can even weave into your summarizing and teach back situation. So the teach back is critically important because you then can see where the person is at. And so when they reflect back to you, you know what level of understanding they have. And then so you can then decide that maybe you want to fight one battle at a time. Okay?
All right, now that you have gone through so many frameworks, the BPS framework, the teach back framework, EPE, let's talk about how to goal setting. So supposing you have a person whose blood cholesterol is very poorly controlled and they have very poor lifestyle making choices. So like I had a patient before who likes to eat bika. Bika has got a lot of cholesterol, right? And then they also have very bad vices like taking laksa and all these fattening curries and all that stuff. In your mind, you're thinking, oh my gosh, the lifestyle is so horrible because there's so much cholesterol they're taking in their diet. Then they also have got struggles with weight loss and they're truly overweight. They have also problems with compliance with all the other medications, not just cholesterol medications. medications. Now, if you worked with a person and you kind of identified that the priorities that this person has made today is to take the medicines appropriately on the correct time, or maybe their decision is to measure the blood pressure regularly, right? Usually the persons that you work with, right, will already have their ideas of what priorities are going to be for themselves. So if they already supposedly did that all that with you, right, don't try and force the person to work on item 3 and item 4 and item 5 all at a go. Now, you all know, right, it's so hard to change a behavior or a habit. So let's try and work with our patient. Don't try and force everything down in one encounter, because there will always be other encounters that come along. So supposing we're saying this person wants to take the blood pressure medicines regularly or all the other medicines regularly, that might actually be the most important thing, right? Because at the next appointment, when you repeat the LDL again, right, you can actually know that the LDL is going to be high because he's going to eat his carb. So let him deal with this compliance problem first, right? Because at the very next appointment, right, you can bargain to say, hey, you know, the next appointment, let's just make a deal. If your LDL is still high, right, then that's when we need to adjust your cholesterol medicines. Is that a deal? You know, this is kind of like the bargaining power you would have to work with your patients that way to give them the feel of the autonomy that we talked about earlier. Right? Also explore ideas on the steps you want to target for behavioral change. Now, maybe your patient says, I think I want to increase my physical exercise. Now, auntie, uncle is like maybe 70 years old, right? You cannot be asking them to go and run marathons or run every day of their five days of their weekdays, right? Be very realistic. Explore on how they think they can also change their behavior. So if they can even tell you, I think instead of taking the lift, I'll walk upstairs because I live on the second floor, then encourage their behavior, right? Remember affirmations, yeah? Lastly, let's try to think about using SMART to set goals, okay? I'm sure this is a concept that a lot of us know about. It's almost like when you study for exams, you kind of, okay, say your exams is in 1 month's time, right? You would plan through all the material you need to revise through. So week 1, you do this, week 2, you do that. It's the same with patients. Make it quantifiable and observable for them so that they also can observe those behaviors, right? And know that they have improved through time. An example is using specific ways of helping them get to that. We can say, you talked about increasing your physical activity. So which days of the week and how long do you think we can aim for, right? You can maybe get them to commit these things. So I've actually done this before with smoking cessation patients, and I get them to write down a contract with me to say which is the quit date, right? And they sign off. It's literally really like a contract. And I staple my name card together with that contract, and I tell them to put it on their fridge, right? So it's specific to say at that day, this is when you're going to quit smoking. That's an example. Make it also measurable. An example is to say your goal is maybe to have increased amount of vegetables, and you say maybe you want to have 4 portions of vegetables a day. Now, not being too, I guess, idealistic about things, right? You know that it's going to be impossible for them to keep a food diary for too long. You might want to say, how do we record that you managed to do that? You can maybe encourage them to say at the end of the day, do a reflection, write down how many portions of vegetables they did that day, and then how they can improve the next day. What is achievable? Maybe this person is someone you're working with to reduce sugar intake, right? You could ask them, okay, so you normally have 100% sugar level bubble tea. That is behavioral change, right? So what might you drink instead? Could you drink sugarless oolong cha, or could you drink maybe tea with fresh milk, right? That would already reduce the amount of sugar in their drink. We also have to be realistic, and remember I was saying you cannot expect a 70-year-old uncle or auntie to start running like 5 days of a week for 15 minutes each time. So you maybe think about working with them to say, how do you think you can do this? How important it is to you to do this, okay? The goals also should be time bound. Don't let them keep pushing you forever. So the example is I mentioned earlier, like setting a quit date, right? They keep telling you, oh, maybe next time lah, next time we can think about it. Or maybe another time I'll think about it. And you know that's a classic excuse giving behavior. So essentially, if you have already identified that this is what you want to work with your patient, make sure that you think about quantifying that for them with respect to time, like set a goal on time. Just like you revise for exam, you think to yourself that there are 12 topics that you need to revise. So you have 4 weeks to do it, you need to do 3 topics per week. So work with your patient to say how long you want to try this for before we review to see whether it's working, because then you can tweak suggestions or behaviors, or maybe activities that you have suggestions for, maybe tweak their medications so that they get less problems with compliance. So elicit for, very importantly, right, what will support or facilitate those decisions and actions or change in behaviors for your patient. At the same time, also think about what are barriers. Okay, so in the example that I said before, right, I've had patients who have very influential friends who maybe go for exercises, or maybe are very strict about their diets. So those are examples that you can encourage for your patients. Say, oh, maybe hang around with these friends more, or think about those examples of how they manage their lives very well. Okay, and barriers are what, like I said, maybe a setting where they have got a lot of colleagues smoking, right? So try to maybe reach out to a colleague or a close friend who can encourage your patient to continue their quit smoking situation and behaviors. Okay, so these are critical examples. And as you do your lab lesson, right, think about how you can use all these examples to weave into your counseling to make it a smart goal for your patient. Okay.
So now that you've identified some of the barriers, right, to the way that they can maybe follow instructions or, the targeted behavior, then you can suggest or offer practical ways to address a person's barriers to change. For example, it might be an auntie who's super fat, right, and she has difficulty even walking up the stairs. Do you think that it's practicable to explore with her to say, oh, you have to exercise 4 days a week, half an hour each time, when she can't even walk up the stairs without panting, right? So maybe you can give her very practical ways first, right? Fight small battles first. Tell her, oh, maybe when you go to the market, instead of taking the lift upstairs, particularly if they live on the second floor, maybe climb the stairs slowly in the morning exercise, right? Even asking them to increase their physical activity like 5 minutes in the morning, just even once or twice a week, is still better than nothing. So always help them to achieve things that they can themselves see that they've achieved it, and then also then affirm them after they've achieved it, rather than nag them to death and tell them, oh, you must exercise 4 times a week, half an hour each time, because that is going to be so difficult for them to even imagine. They can't even start in the first place. Yeah, so I hope that in that illustration I have given you an example of how to give them practical ways of behavioral change. So now that you've heard all that boring theory, I'm sure you're ready to start, right? So in order to start, please review the nice handouts that I've put into Luminous for you. Review the non-pharmacological advice that you need to give a person with hypertension, right? And review the own handout which you have created for CLW1 in PR2153, which is the CVS module. Okay? So with that, let's start the exercise.
Okay, everyone, I'm sure you're all raring to go now that you've heard all about the frameworks and you're so waiting to start your skills class. So I've also uploaded two different pieces of information for you, and they're called the Care Team Communication Rubric and Guidance. This first screenshot over here is the guidance, and it gives you examples of how you could state your case. So they will be corresponding to the various rubric competency areas of C1 to C4, C5, C6. And in the middle are examples of how you could state your case. The last column is examples of what you should not use in terms of language. There's a second document that tells you a descriptor of where a healthcare professional could be with respect to the skills or the language that they've used with working with patients. So there are different levels there: the beginner, the learner, the practitioner, the master, and of course the expert. Now, we're not expecting you as pharmacy students to get from zero to expert, of course. It's critically important for you to explore what are the descriptors of behavior, and then use this rubric, right, to grade behaviors of role plays that you're going to see in skills class in the coming weeks. Okay, so always bear this at the back of our minds, and essentially I just want to give acknowledgement to the Ministry of Health team, and also to tell you that this particular rubric, right, was developed as part of an FYP project, believe it or not. Okay, so with that, I hope that you guys are just as raring to go as I am, and you will start to see how shared decision-making skills are so important in co-developing goals with your patients. I've seen the profound effects of SDM on our patients, and it really is very rewarding when you try to change behavior for a person who's deemed to be non-compliant or naughty or refuse to listen to instructions. But with you in their care, right, they can have all their diabetes, blood pressure, cholesterol issues being controlled. All right, so I look forward to seeing you guys in class. Bye, guys.